I'm James Surowiecki, the business columnist for The New Yorker, and we are here today with David Cutler, professor of healthcare economics at Harvard, and I would argue the most important healthcare economist in the United States today. David Cutler was a senior policy advisor to Barack Obama during his campaign on healthcare. I think he's been one of the most important figures in shaping the discourse around healthcare in recent years. So thanks very much for being here.
It's great to be with you.
Great. So as we talk, the Congress and the Senate specifically appears to be on the verge of passing this healthcare reform bill. Let's start with a simple question. What do you think of the bill as it's being considered right now?
Well, it's an amazingly good step forward for the country. It's something that we've been trying to do for about 80 years or so, so maybe the time is finally ripe. In terms of my scorecard, I think about it in three principal ways. One is, what does it do by way of covering people, where the Senate bill, the estimates are it would cover 30 million more plus people. I think if we play our cards right, we can get much higher than that.
Okay.
Second is, what does it do to modernize the healthcare system so that it works better for people and costs less? And I think there are a number of wonderful things in the bill that people have not taken account of that really would do very well.
Okay.
And third is, what does it do about our public health infrastructure, about our ability to live long, healthy lives? I think it does okay there. Overall, it's an immensely important bill and wonderful for the country. I personally like having a public option, mostly because I think people should have the choice between a public plan and a private plan if they want, and what's wrong with giving people choice?
Right.
But I've been surprised that we focus so much on that as opposed to how much we're giving in subsidies for people, how much we're doing to reform insurance markets, how much we're doing to save money in the bill. It's a bit surprising to me.
In some ways, this is primarily a health insurance kind of reform bill. It's transforming the way Americans get insurance, especially those that are uninsured currently. What are the most important elements of the bill in your mind in that regard?
In that regard, I think the single biggest issue is the insurance exchanges. The philosophy behind the bill is that insurance works well for big companies and it works awfully for individuals and small firms. Okay. So in big companies, you get a choice of different plans. The employer is bargaining with the insurance company, hey, you got to lower your rates, and people are generally fairly happy. Within small firms, it's catch as catch can. Your premiums this year are going to double. Don't ask us why. If you don't like it, go somewhere else. By the way, we may exclude some of your employees or some of the particular conditions of your employees. So it really works awfully. And the philosophy is let's bring to individuals and small businesses the benefits that big firms get.
Okay. In the past, insurers kind of competed by figuring out how can we avoid sick people and get as many healthy people as possible into our pool, basically. And the idea is now you can't really do that because you're banned from charging them more if they're sick, et cetera, et cetera. So you're going to compete on quality, customer service, and then also on keeping people healthy. And you view that as a genuine possibility given what's happening?
I view that as a possibility. I think that's people's goal, and we'll have to figure out how exactly to make that work. I think we're actually well on the way to doing that, and it would be a very different experience and a wonderful change.
Right. Now, people are sometimes skeptical that competition can work the same kind of magic that it does in other markets, in insurance. How far toward helping competition work will the exchanges go, do you think?
They will go a long way to it. They will be the enforcers of the regulations. They will be the ones that if an insurance company is not delivering what it says it should, that they will have to take action.
Now, you're the co-author of a study that came out this summer, I believe, from the Commonwealth Fund and the Center of American Progress that said that, in fact, the bill would, in fact, be able to lower costs. Because that's been one of the criticisms of the bill from the right or from centrists, that, in fact, it's not going to cut costs at all. Now, intuitively, I think to a lot of people, you say, we're going to cover 30 million more people. People say, how could that possibly bring down costs? What's the answer? How can it bring down costs?
Every study that we know of says that the U.S. medical care system is bloated and inefficient. That costs in the U.S. medical care system are probably a third higher than they have to be. we're going to spend on medical care about $2.5 trillion this year. So about $700–800 billion is wasted. What are the examples of that? Administrative costs that are way too high. Every middle manager who used to work in every other industry, they now all work in healthcare. At Duke University Hospital, they have 900 hospital beds and 1,300 billing clerks. Get admitted to the hospital and get 1.5 billing clerks with your admission. So administrative expenses. Errors. It's estimated that anywhere from $20 to $100 billion a year is spent dealing with mistakes that are preventable. People get more acute care than they need. People get tests when in other areas of the country or in other countries they don't happen, and there's no clinical evidence that they're doing anyone any good. In fact, they're just exposing people to radiation that they don't need. Just give another example. If you look at what nurses do in hospitals, you look at the most common thing that nurses do, they're documenting things. They're taking a printout in the patient's room, bringing it to a nursing station, and entering it in a computer.
How is that efficient? It is not.
Is there any industry in which that would go on?
Right.
So I have yet to meet a person who's involved in a healthcare business who thinks that they couldn't save at least 25%.
Does the bill that the Senate is considering now do anything to really touch those issues?
It does. It does quite a lot, actually. One way that you get at that is you say, let's turn insurance companies and have them focus on that problem. So that's what all the getting rid of the underwriting and thinking about how do you really serve people well. The biggest example in the bill, what's really driving this bill, is the idea that the 800-pound gorilla, which is the Medicare program, should be the leader in doing this. And so what a lot of the 2,000 pages of the bill are about is turning Medicare away from a kind of robotic program where it just collects bills and pays them and collects and pays, into a kind of smart purchaser that says, you know what, if you've got some way to keep people out of the hospital that both improves their health and saves money, great, let's figure out how to do that for all of our beneficiaries. And if you've got some way that will manage disease better or make sure hospital costs come down, great, let's do that too. So let's take everything that we know and try it and see what happens. There are a couple ways it could fail. One is we could appoint lousy people to run it in Washington.
Okay.
The second is the private sector, the doctors, the hospitals, the insurers could decide to spend the next decade fighting it instead of actually dealing with it. And I think all the provider organizations are going to have to say, it's a new world. I have to figure out how I'm going to adapt to it. Just to take a common example, the rate of hospital-acquired infections in hospitals, very high. Hospitals, people get infections much more than they ought to in hospitals because doctors and nurses are not washing their hands frequently enough, dressings are not changed frequently enough, patients' beds are not elevated, a variety of things like that. We know from examples across the country that it's possible to drive those rates to basically zero. You can completely eliminate them, and yet not all hospitals do that. In fact, a very small number of hospitals do that. It's going to have to become the norm that we eliminate defects, just like it's the norm everywhere else in the economy. And that's going to happen because leadership has to be there, and the leadership has to say, you know what, doctors, we like it when you practice the way you want, but this is one instance where you cannot practice the way you want without washing your hands and so on.
You need to follow that checklist.
You need to follow that checklist. And look, it's better care. You know it, we know it, so let's figure out how to make it happen.
Atul Gawande, one of our writers, wrote this piece that got an enormous amount of attention this June about McAllen, Texas, about the way in which a kind of culture of action kind of developed. And obviously that's a huge issue. I mean, these massive regional variations in treatment. How do we change that?
The thing that we've learned about healthcare the most in the past 10 or 20 years is that you can, for good or ill, have enormous impact on what's done by changing the financial incentives and the information that's available to the providers.
So doctors are not making pure platonic decisions about what's the right thing to do and the wrong thing to do.
You know, they're doing what's best for their patient, but if you think about how the system knows what's best for the patient, you know, one of the most amazing thing about Atul's points about McAllen, Texas is they had no idea they were the most costly area of the country outside of Miami, Florida.
Right.
And if you go to any provider and you say, any hospital, and say, tell me, how's your rate of hospital-acquired infections compared to the other folks? Well, I have no idea. And it's not because they don't care about their patients. It's because it's not presented in any way and the incentives are not there to deal with it. Once you get the information there and the incentives right, you can then have an enormous impact.
Okay.
And that's really what it's got to be about. It's got to be about creating a system where you give them the right information, you hold them accountable, and you give them the incentives to do it right.
In a lot of industries, this kind of benchmarking, this kind of careful monitoring of what others are doing is pretty common.
Yep.
Why doesn't that happen, or hasn't that happened in medicine?
You know, the interesting thing about most of American business is that it's become much more productive in the past decade.
Right,
productivity growth has been enormously high because of these sorts of things. I think it hasn't happened in healthcare partly because it's been more difficult, so we haven't had the information. But a big part has been, well, I should say two things. One is that Medicare has been essentially brain dead. So you have the single biggest insurance company in the world not doing a thing to promote quality.
By brain dead, you mean just paying
and not. We knew well over a decade ago that 44,000 to 98,000 people a year were dying because of medical errors.
Right.
We are just getting around in Medicare to not paying for those medical errors. And the private insurers were just going very slowly on it because the incentives were there to make money in other ways. There are a few different ways to deal with it, and they all rely on having a good information base around, because name an industry that ever got better without knowing what it was doing.
Right.
There aren't any.
Right.
So how do you do it? One thing you do is you come up with measures of good performance, and you say, if you do good on the performance indicator, we're going to make it worth your while. That's the diabetes example.
Okay.
If you have good measures on diabetes, yes, even though you're not going to save money because the money gets saved for someone else, we're going to make sure that you get compensated. Second is you break down the silos. So there's a silo now, which is a hospital, and there's another silo, which is the primary care doctor.
Okay.
And very frequently, a primary care doctor never knows a patient went in the hospital, and they never know when they come out. By bundling those payments, you all of a sudden say, you know what, you folks are going to make money if you figure out how to communicate with each other. And by the way, we've just put $30 billion on the table to set up the information systems that will let you do it.
Okay.
So don't come to us and tell us you don't have the money. Don't come to us and say you don't know how to do it. And then you do a lot of kind of helping the patient do things. So you say, look, if you help the patient deal with their chronic disease, we can make sure that's worth your while. The worst thing we ever did in healthcare is we thought about the industry as being the hospital or the doctor or the pharmaceutical companies. No one I know cares who physically provides their medical care.
Right.
They care, did they get better?
Right.
So we have to make did the patient get better be the operative idea. If you look at the progressive healthcare organizations, ones that are doing very well, the structure of how they operate is completely different. They have teams rather than individuals. They figure out how to manage care in a good way rather than just how to dump people. They bring in specialists when they're needed, and everyone's working together. They work with the patients. The health partners example you brought up, they're working with the patients, not at odds with them. So it's really an approach that says that good care is both better for the patient and cheaper overall. What this bill is about, along with the stimulus bill with the IT, is laying the foundation, building the road that we can travel on. It's then going to be up to us to make it work for the next decade, so that 10 or 15 years from now, the healthcare system looks very different from what it does now. We waste an enormous amount of money because we can't figure out who really benefits from things, or we don't apply what we know about who really benefits from things versus who doesn't. And so there's this sort of dual-edged sword to it. What people worry about is that healthcare reform is a code phrase for give up all the technology that they like,
right,
which it's not. In fact, the thing that's going to crowd that out, if anything, is all the wasteful stuff that then means we have to ration in other ways.
In terms of information technology, that's the one that we feel like we've been hearing about it forever. Yep. Health IT,
yep.
But as you said, they're still
yep.
Carrying papers. What can health IT do, and why hasn't it been utilized fully yet?
It's an interesting case study of everything that goes wrong in healthcare. So we've known about electronic medical records for quite some time. If you go to any doctor's office and you say, why don't you invest in an electronic medical record system? They'll say, nobody pays me for it. If you go to the insurance companies and say, why don't you pay the doctors? They say, because nobody pays us for it. And besides, I don't want to pay when the other guy could pay.
Right.
So you go to the businesses, you say, why don't you push the insurance companies? Why don't you give them extra money so they can pay the doctors more so they can invest in the electronic medical record systems? No, we need to limit our medical bills. We're not paying them. Besides, shouldn't they be doing that already? So there's this situation where everyone just stood yelling at each other. The Obama administration came in and said, you know what, we're just going to cut through this. Yes, we want to change the payment systems. We're going to do that. That's what's on the table now. But in the spring, they said, we're going to do IT. We're going to make their $30 billion there. You folks are going to get it or else.
There's $30 billion in the stimulus bill for health IT.
For IT. Buy it, use it in the right way. Don't come complain that you can't do it anymore.
And do you view this is really going to transform the way people use information technology?
Yes, but it's going to be more than just having a computer there. As I'm absolutely totally convinced we could get a computer on the desk of every doctor. It would be a very nice paperweight. It would take up a little bit of space. The key is going to be to use it. And so you have to have part two, which is how do you use it well. An analogy from other businesses, most businesses when they bought computer systems in the 80s and early 90s, used them as substitutes for typewriters. So it's a little bit easier to correct. You don't have to retype the whole page and so on. Now, that's a little bit of value, but in fact, that was not a whole lot of value. Where computers really turned out to have value was when you integrated them with the workflow so that the right information got to the right people, that when someone entered information, it showed up elsewhere so that you could actually plan how to do things, so that employees had all the information that they needed. So it's going to be the integration of information into the medical system that's going to make it work, not just the physical act of the record is now on a computer rather than on some paper somewhere.
How optimistic are you that actually this bill is the first step in a successful transformation of the system?
I think we certainly have the capacity to carry it through. We being the government, we being the private sector, have the capacity to carry it through. So far, if you look at the people who could derail things for the next decade by fighting it, they're not doing that. They're accepting that the world is going to be different and that the insurance companies, even though they've done a lot of things I don't like, they're basically hanging in there. The doctors, the hospitals, all the providers. I have confidence in this administration's ability to do things. So far we're on a good, very good start. The next couple of years are going to be absolutely critical. There's going to be a phase where firms are figuring out what to do, how do I deal with it, and we have got to be able to manage that well. And it's going to be incumbent on everyone who wants this to succeed, businesses, people in academia and so on, to say, how can we help make it succeed? The consequences of failure would be unbelievably bad.
All right. Well, on that semi-optimistic note, thank you very much for being with us today.